Hello, my name is Seconda Udoye. We're going to be presenting a case study about a patient's emergency department experience. And presenting with me will be Mary Ukpabi-Egbuniwe, Catherine Nwokeafor, and Nnenna Onyeukwu. Next slide. Our story is about a patient at the emergency department who visited for a broken femur at age 10. The ED physician recommended surgery and referred patient to ED orthopedic specialist who did not think surgery was needed. However, injury healed within 6 months, but pain returned a year after. Patient consulted with private orthopedic specialist 2 years post-surgery and was treated with pain medicine. Next slide. Pain got worse. Consulted with family physician and was referred to another orthopedic specialist. Referred to surgeon by third orthopedic specialist. Consulted with surgeon a month later. Patient-centered care achieved using shared decision-making. Surgery was done and surgeon continued to follow up care. I'm gonna hand over to Catherine to talk about the relevant domain.
Hello, my name is Catherine Nwokeafor. I'm here to present the relevant domain for our patient lived experience in emergency room. Our domain for this storyline is respect, patient preference, and shared decision making. Respect for patient reference from patient-centered approach simply means care that is respectful and responsive to individual preferences, needs, and values. Shared decision-making is the process whereby clinicians collaboratively help patients to reach informed and value-congruent medical decisions. Patient-centered approach necessitates open sharing information. Institute of Medicine postulates that care should be competent, safe, and successful to yield a better outcome. Nnenna also postulates that policies should acknowledge the rights of healthcare consumer, that's the patient, to use other alternative modalities as needed. Preference domain expects providers to show respect and treat patients with dignity. Providers should also see patients' perspective and show emotional support during care delivery. Next. Providers should discuss risks and benefits of every treatment options available. Provider and the staff should allow patients' voice in treatment decision making. Although this patient lived experience yielded expected better outcome at the end, however, the patient's rights, preferences, and decision makings were violated initially in the care. Although the domain for lived experience pointed at preferences, respect, and shared decision making, there is interrelationship among other domains as depicted in Nnenna's conceptual framework, whereby trust and distrust and communication is also factored. Thank you. I'll now turn over to Mary to tell the story of the patient.
Hello, my name is Mary Egbuniwe. I will be reviewing discussing the discussing portion of this presentation. Patient is an autonomous individual with a health problem seeking initial care through an ED physician. This patient has a desire to be involved in the decision-making process for treatment options. According to Say and Thompson, this is an important part of a quality improvement. The ED physician had initial contact with the patient that organized the problem and relayed the risk associated with inadequate care. He also desired to increase patient involved and recognize current and future patient preferences. The first orthopedic specialist had contact with the patient and failed to recognize the needs, to respect the patient preferences or shared decision-making. He also failed to recognize the patient as the expert with unique knowledge of their own health. Second orthopedic specialist failed to treat the root cause of the problem and instead resulted to symptomatology-based care. There was a failure in partnership between the doctor and the patient. Family physician was the first follow-up provider who recognized the patient's autonomy and the need to respect the patient's preferences and involve the patient in shared decision-making process. He referred the patient to the orthopedic. The third orthopedic specialist examined the patient following the referral from the family physician and discussed the treatment options available while respecting the patient's preferences and acting as a liaison between the patient and the surgeon. Co-management of the patient with respect of their preference and self-expertise leads to improved health outcome. Finally, the fourth orthopedic specialist, who is the surgeon, performed the surgery. He recognized patients with a unique knowledge of their own health and their preferences for improved outcome by having final involvement with this patient and recognizing their knowledge and expertise, their health states, preferences, and desires. According to Say and Thompson, increased patient involvement is an important part of quality improvement since it has been associated with improved health outcome. Thank you, and now pass you over to Nnenna.
Hi, my name is Nnenna, and I'm going to be talking about the potential solutions. Now, I'm going to do that using the 8 principles of patient-centered care, such as continuity of care and follow-up, coordinate and integrate patient care, provision of physical comfort, provision of emotional support, provision of access to care, education and information and decisions, and have respect for patients' views, values, and preferences. For this particular case scenario, there were 6 clinicians involved. The ED physician, the ED orthopedic specialist, the patient's primary care physician, the second orthopedic specialist, the third orthopedic specialist, we have the surgeon, and that's 8, I believe. So we talk about the respect for slide number 2, please. So the orthopedic surgeon and the referring orthopedic specialist applied patient-centered care. They encouraged active collaboration and shared decision-making. They applied all the patient-centered care principles, and the coordination and integration of patients' clinical views were evident. Slide number 3, please. Now, there was lack of emotional support and denial of access to care by the ED orthopedic specialist who refused to perform surgery on this patient, as well as the private orthopedic specialist who did not refer this patient to a surgeon but proceeded to treat the patient for pain. And then they denied her physical comfort initially because this patient was in pain until she finally saw the orthopedic surgeon. And then the ED physician and the primary physician gave her access to care because they referred her each to the specialist who referred her to the surgeon, and then the PCP, primary care physician, referred her to the third orthopedic specialist. And then through, that visit, she was informed and educated on the potential outcome of, by both the ED physician and the PCP. So she was referred to the orthopedic specialist, the orthopedic surgeon, beg your pardon, by the third orthopedic specialist, who finally performed the surgery, and then the patient was able to experience comfort and emotional support, and she was free of pain. And this brings the presentation to an end, and now the references. Thank you.